Hello, everyone. So one of your teammates had a good query, and I thought it would be easier to make a video out of this rather than write it out because I don't know. I feel that medical nutrition therapy is one of the units where it is better to verbally, step by step, explain things to the students because it makes more sense as it's very clinical in nature. So I try to make videos as and where possible to provide further explanation. So one of your teammates asked is that you have this online module lecture on oral nutrition supplementations. And how do you choose which oral nutrition supplement to provide to a patient? So there are a few parameters over here to think about. The first one is that in real life, in practical life, this is based a lot upon the hospital availability. All right, so you have this beautiful handbook, and you have around, say, 20 or 25 supplementations listed in your pretty handbook. So you have an entire chapter on nutrition support, right? So yes, but you don't get all of these supplements in each and every hospital. So the hospitals, they have contracts with certain companies, so and so, and then you are restricted to the supplements available in the hospital, and you have to provide the best clinical output on the supplements which are available. So that is the real life thing. All right, but more importantly, how do you choose which oral nutrition supplement is good for your patient? It depends upon the patient's requirement. All right. So, for example, if you see that your nutrition support chapter, which is there, if you look at the heading of the table, so you have these various tables, and the heading clearly lists that these supplements are, say, approximately 1 cal per ml or 1 to 1.2 cal per ml. Then you have a second table which tells you that these supplements are 1.5 kilocal per ml. And then you have another table which tells you these supplements are 2 cal per ml. So you have these supplements listed according to the caloric requirement. Now, why is that so important? Why? Because, for example, if we take 2 cal per ml, you don't give this to every patient just haywire. You don't do that. You give this to patients who may be on fluid restriction, volume restriction, when you want to give the patient a lot more calories, but you don't want to increase the volume so much because the physician has said that the patient needs to have a limited amount of volume, and you need to punch in a lot more calories in that limited amount of volume. All right, so that is when 2 cal per ml is generally used, for instance. All right, 1.5 cal is also used when there is increased volume requirements. It has more calories per ml compared to, say, 1 cal per ml. All right. So yes, these 1.5 and 2 cal per ml, they are generally used depending upon the severity of the volume restriction, fluid restriction that the patient has been advised. That is when we use this. This is, say, one of the broader examples that I'm telling you because I'm introducing you to the topic. Of course, there are much more permutations and combinations to think about. But when you're learning something very new for the first time, go to the very basics, the most basic principles, and then you will gradually build on your knowledge when you go from MNT1 to MNT2 to your placements to becoming fantastic dietitians. Okay, so when is 1 cal per ml? That is the one which is used almost always for generally most of the patients. And also 1 cal per ml is used when your patient has, say, when your patient is susceptible to, say, osmotic diarrhea, for instance. So you can't have a very high solute load. All right, when you have a very high solute load, this can lead to diarrhea for the patient. So when I was working in the hospital, when did I use a lot of 1 cal per ml? When I had GI patients, say, who had gone under GI surgery, such as colonoscopy and jejunostomy, where you are like cutting parts of the, say, intestine, which is affected, which is not working well, and the intestine is shortened now. So when you have a shorter intestine, logically the food which passes through the intestine is much more faster. The speed increases because there is not a lot of, say, length remaining for the food to pass, all right, for the nutrient to pass. So over here, if you have a very, very high solute load, something like 2 cal per ml, this can take water from the intestinal cell and this can lead to osmotic diarrhea. So with my GI patients, who were very highly susceptible to osmotic diarrhea, for example, that is when I also used 1 cal per ml. Of course, as you can respect and appreciate, oral nutrition supplements generally are used for malnourished patients who are at risk of malnutrition or who are already severely malnourished. So yes, that is when you want, when they can't meet all of their requirement from food, that is when you rely on oral nutrition supplements, which may complement food. All right. So yes, this is roughly the scenario. Like, so one of the decision-making levels is according to the caloric requirement, and according to the patient's clinical condition is when you decide what type of supplement is the best. All right. So that is one reason. Second, you may have seen in your handbook, it is also listed as per disease condition. So you have, for example, high arginine supplementations, which are really useful for wound healing. Why? Because with wound healing, it has been seen that arginine plays a very important role. The biochemistry behind it, it plays a very important role in helping wounds heal. So you may see this with a lot of surgical patients that have been used, or burns patients that have been used, where you want rapid recovery and wound healing happening. So for example, that is when arginine supplementation may be used. Then for example, you have kidney. I'm sorry, over here I said kidney diabetes. But yeah, so you have kidney conditions, and in kidney conditions, for example, these supplements may be, say, lower in say electrolyte concentrations, because the kidneys are not working well and they cannot filter these water soluble electrolytes very well. So these supplements could be lower in the electrolytes. Then you have, say, for example, low glycemic index supplementation for diabetes. You may use certain, for very simple cases, like say a person who is just more prone to diarrhea, you may want to use a fiber-free supplement, or who's on a low residual diet, you may want to use a fiber-free supplement. Or a person who is very susceptible to constipation, you may want to use a supplement which contains fiber. So it could be 1 cal per ml, but with fiber. But then you have a low residue patient. For him, you may be 1 cal per ml, but fiber-free supplement. So there are these various permutations and combinations which are possible. And it really depends upon the clinical case. But I hope this gives you a bit of an overview as to what are the, say, basic parameters you may consider in deciding the use of oral nutrition supplement. So I hope this has been helpful. And yes, I'll see you in the next one. Thank you.